Okay, well, welcome everyone for this next edition of Global Obstetrics Journal Club, and I'm Professor Stephen Tong. I'm one of the co-hosts of this, and so this is a presentation with Mercy Perinatal with Scan Academy, and representing Scan Academy based in the UK is Iris Papageorgiou. So we have a very interesting paper which has garnered quite a lot of interest in Australia, and it sounds like a little bit around the world. It is an interesting paper just comparing the outcomes between private obstetric maternity care versus public care in 3 states in Australia. And this is a paper that was published in the British Journal of Obstetrics and Gynecology. We do acknowledge that it's garnered much interest. It's had some buy-in by, I suppose, people with, pre-existing ideological interests. So others have emailed us just asking us to objectively look at this paper, and we're very glad to do so. So the brief that we're going to put to the panelists this evening is very simple. We're just going to ask the panelists to stick with reviewing the methodological rigor of the study design and execution. We're going to try to keep it with unbiased by a priori views, therefore a pretty neutral look at the paper. I have to say there are people who have interpreted perhaps a little bit coloured on their background of what they practice. I'm sure not many people, but a few, but we've done our best to choose a panel where that won't happen. And so to minimise that, we've really stacked the panel with experts from outside Australia, and really top experts. I might also note that usually for Global Obstetrics Journal Club, we have an author interview. That fell through. So the first planned time, it was completely my absolutely terrible diary malfunction. And unfortunately, we were unable to then secure a subsequent interview with the author. So apologies for that. But like usual, Global Obstetrics Journal Club, after our intro, we're going to have the paper presented and we'll have a really good panel discussion. So speaking of the panel, we really do have an incredible group lined up. So we have the firepower of Iris Papageorgiou, who's at the University of Oxford, and we have Gordon Smith, who's at Cambridge University. And so I'm just saying that we have the intellectual firepower of Iris in a region of Oxford that produced 73 Nobel Prizes, and then we have Cambridge, which had 125 Nobel Prizes. And then we've got a number from Australia getting up there with 15 Nobel Prizes. So we've got a lot of intellectual firepower. So we've there also got Jenny Myers from Manchester University. And significantly, we've got some serious editorial muscle. So we've got British Journal Editor-in-Chief. We've got Gordon Smith, who's one of the academic editors of PLOS Medicine, a very eminent journal. And also Jenny Myers is also a PLOS Medicine academic editor. So we've got really clever people in the room. And another absolutely clever person in the room, it's my pleasure to also say that Professor Christine East, she's a professor of midwifery at La Trobe and Mercy Health, but as she'll say, she represents her own views tonight, as we all will. And we've got from our Mercy Perinatal team, the legendary Professor Sue Walker. She's actually in London right now, so thanks for zooming in, Sue. And shortly, I'll bring in Associate Professor Roxanne Hasty, and she's going to present the data, and she's well qualified to do so. She's done many similar complex statistical analyses. She's not clinical in background. It shouldn't really matter, but perhaps tonight it's probably advantageous to have someone who's non-clinical presenting the data, but she's a superb perinatal epidemiologist, and she'll be presenting the paper this evening. And so we have over 1,800 who are registered from 70 countries right across the globe. Welcome Azerbaijan, India, Nigeria. There's lots from Australia, over 900, and a good over 50 from UK. I might also acknowledge Bella, who's here helping with tech support, who's just amazing. Just a little plug, if we just might. We've got Global Obstetrics Update GoU 2025, and we've got an incredible lineup of 7 international speakers coming in all around the world. Really top-notch program. I might also just mention very quickly for GoU this year, that we've been very proud over the years that if there is, we keep our ear to the ground. If there's something exciting, something contemporary, we'll just change the program. And we've done so. So you just really shouldn't miss it. So we were speaking with Professor Kathy Kluver, and she's done 3 very important Cochrane updates. So remember the first Global Obstetrics Journal Club, we discussed a paper published in BJOG, just noting that calcium, there may be doubts whether calcium may be able to prevent preeclampsia. That led to her watching it. She approached WHO. She's updated the Cochrane review of calcium to prevent preeclampsia. Mustn't miss it. The second Cochrane update she's done is the timing of birth when you have preeclampsia, and that data might surprise you. And the one that might really surprise you is we all rely, perhaps, or maybe just we rely on tranexamic acid to reduce bleeding, but does it really? She's updated the Cochrane review. She's going to present and release all that data at GoU 2025, so you mustn't miss out. Now, we do have 80 in the waiting list for the face-to-face, so you're probably unlikely to get in the room, but please do join us online. Those from low middle income countries defined by World Bank, please email us because we're going to send you a free online link ticket. Just preceding GoU is a new initiative, a new conference we're running, Global Research Obstetrics Update. So this is a scientific update. We're just bringing in right across Australia the top-notch Australian scientists trying to find better tomorrow for pregnancy health. And we've also got lots of our international speakers who are coming to GoU also participating to that. And it will be pitched to not just researchers, it will also be any clinicians that may be interested. And lots of brilliant people presenting. But if I might just note one, just imagine, and I was on Birth Suite yesterday and I would have loved such a device. Just think, no, actually that is going to be actually a GoU talk. So I'm just going to tell you anyway, come to GoU because Jonathan Morris is going to tell you about an incredible revolution in the horizon, and that's continuous scalp lactate monitoring. Absolutely stunning stuff. But please come to GoU, lots of excellent talks on the way. So Global Obstetrics Journal Club, we've got a super interesting paper, and it's my absolute pleasure to bring onto the virtual podium Associate Professor Roxanne Hastie to present this very interesting paper. Thank you, Rox.
Thanks, Stephen, and for that great introduction. It's so nice to be back at Global Obstetric Journal Club. So I thought this evening it would be a good idea to give a bit of an overview of what pregnancy care in Australia actually looks like, especially for our overseas listeners. So in Australia, women have different options and models of care that they can choose from. And this includes, of course, our public standard maternity care. And so this is our free universal healthcare that can be accessed for free by anyone with a Medicare card, so Australian citizens and Medicare holders. In addition to the standard maternity care, we also have private obstetrics. So in this model, women are able to choose their private obstetrician prior or in early pregnancy, and this obstetrician follows them throughout pregnancy and birth, and they are also supported in the hospital by midwives as well, of course. In addition to public and private, we also have midwifery group practice. So this is where women are supported one-to-one with a midwife throughout their pregnancy, but they're also part of a small team that if their midwife isn't available, they see people in the team that they know, and this provides continuity of care for women. And importantly, the midwifery group practice is within that public standard care hospital setting. Women can also elect to see their general practitioners in the community, so they can see their GP for some of their antenatal care, and this is GP shared care. So the majority of their antenatal care is done by the GP, but with visits as well to the hospital, and then birth again within that public hospital setting. And we also have private midwifery. And so this is again similar to private obstetricians. Women can choose their private midwife, and this midwife will facilitate their antenatal care and also their birth in either a home birth setting or support them in a hospital birth setting. And so these models of care are so important to providing safe and effective care across the country, and they really do work hand in hand. But to go a little bit deeper into what are the exact differences between standard public care and private obstetric care in Australia. So the cost for standard care, it's, as I said, universal free healthcare and covered by Medicare or the public hospital funder. So this is mostly free to the patient. There are some costs if you're having your ultrasounds and genetic testing done outside of the hospital. The providers are largely midwives and general practitioners and obstetricians if needed, but women will see an obstetrician at least once in their pregnancy, and more so if they become more high risk or more complicated. So for continuity, women will see different providers at their appointments and also in the birth suite, unless, as I said, they're in that midwifery group practice or doing GP shared care. But continuity does also differ between different hospitals. So for postnatal care, the stays are often a little bit shorter in that standard public care, but they do have midwife home visits within the first couple of weeks postpartum. In terms of level of care, well, this is tiered in the standard public care, and there are 6 levels with referral pathways. And so these referral pathways are very clear, and the top level or level 6 tertiary centres are those that can manage high-risk patients or very complicated pregnancies, and they have neonatal intensive care units that can also manage births from those very early preterm gestations, such as 22 and 23 weeks. But in our private obstetrician care, so this is private insurance, so women will have a private insurance policy that they pay for and an additional premium that they must have for 12 months before they can access their private health care for pregnancy, plus additional out-of-pocket fees for the obstetrician themselves, but also out-of-pocket fees for additional specialists such as anaesthetists, paediatricians, and anyone else that they might see in hospital. So the provider, as I mentioned, is a private obstetrician that the women choose themselves, and the continuity is then that same provider throughout their antenatal care and in birth, as well as, of course, important support from midwives in the birth suite and throughout their hospital experience. Postnatal care, this is often longer when compared to the standard public care, and partners are able to stay. And in some hospitals in Australia, you can also stay in a very lovely 5-star hotel if you're low risk as well for the end journey of your hospital stay. And the level of care, the obstetrician leads this, but more complex cases are often referred to the public tertiary centres, so those level 6 centres, when they know that babies might need a NICU or mum might need more complex care, or that multidisciplinary team that is provided in the public system. So there is those very clear referral pathways. And important to note that most private hospitals are accredited for birth in their special care nurseries from 32 or 34 weeks. So not typically seeing those very early preterm births or planning those early preterm births in the private setting. But again, just wanting to note that how important it is that these systems go hand in hand to support women and offer safe and effective care across the country. The private system is so important to alleviate some of the pressure on the public system, and the public system is there for those more complex cases and those high level of care. So really, again, going hand in hand to work together. But what's less clear and hasn't been well studied before is whether there are differences in maternal and neonatal outcomes and costs between these two systems. And so that leads us to our paper this evening. And this was a publication published in BJOG in July of this year that looked at maternal and neonatal outcomes and health system costs in standard public maternity care compared with private obstetrical care. And this was published by Emily Callender and their team at Monash. And as Stephen's already mentioned, this publication has certainly caused a little bit of a divide between some of the people practicing in maternity care at the moment. And so I'm just going to say from the outset, it's my job this evening just to provide you an overview of the study and to really highlight the strengths and limitations so that you can then draw your own conclusions from these results. Okay, so let's get into it. What did they do? Well, it was a retrospective cohort study that took births from 3 Australian states from 2016 to 2019. And I think the team should really be congratulated on this. As someone who works in perinatal epidemiology, I know how hard it is to get birth data from one state, let alone 3. So a very big effort, and congrats to the team on this. And they undertook a matched analysis. So this means that they matched women 1-to-1 based on important maternal demographics that they had in their data set. And we'll go into this in a little bit more detail shortly. And they looked at health costs as well as clinical outcomes. And so Their cohort initially included 661,451 births in the standard maternity care group and 202,236 births in the private obstetric care group. But we know that women who are accessing the private obstetric care group are different to those in the standard maternity care group. And this was very clear in the publication, and the authors looked at this and showed that in their population, women in the standard maternity care group were younger, they had a higher BMI, they were more likely to be Aboriginal or Torres Strait Islander, they were more likely to be born in a non-English speaking country, more likely to be a smoker, more likely to have a lower socioeconomic status, and more likely to have diabetes or hypertensive disorders, both pre-existing and those that develop in pregnancy. But they were less likely to have conceived through assisted reproductive technologies. And these differences are really important, and it makes them difficult to compare these two groups. So this is basically like comparing apples and oranges. And so to overcome this, the team undertook a matched analysis. So all that means is that they took those variables, Aboriginal Torres Strait Islander status, smoking status, country of birth, BMI, plurality, parity, age, diabetes, smoking, hypertensive disorders, and ART, and they matched women in the private group to those in the public group based on these demographics, and this was a 1-to-1 match. And so this aims to balance out those differences and make the groups a bit more comparable. It's important to also note, though, that the team could only work with the data that they had, and that for one of the states, they did not have data on BMI or assisted reproductive technology conception, and also smoking from one of the other groups. And there may have also been some missing data within these as well. So matched to the best of the ability with the data that they have, but again, not completely matched. But if we look at a little bit more closely at the effect of this matching, so this is just a part of their table 1, which just shows their background characteristics for each of these groups before matching. So we can see again that the women in the standard care were younger. They had much higher BMI, of a mean BMI of 34.8. I think the standard deviation there might be an error in the paper. I don't think it would have been 89.5. There was a more likely to be Aboriginal or Torres Strait Islander, born in a non-English speaking country, more likely to be a smoker with 9% versus 0.5% in the obstetric care-led private group, more likely to be nulliparous, and more likely to have utilised ART in the private group, 12% versus 2.7%. But after matching, these differences were largely attenuated. So we can see that the difference in mean age is slightly less, but still a little bit of a difference. So 32 versus 33 in the private group. They weren't able to completely balance out the difference in mean BMI, with a mean BMI of 30 in the standard group and 26.7 in the obstetric care group. But the proportions between each of the BMI groups were similar. The rest of the variables they were able to balance out. So it seems that after their matching, they were able to balance out the variables that they had. Okay, so what did they find? They looked at quite a few numbers and a few outcomes, I think over 20. So we're going to break them up into different categories and first look at mode of birth. And so looking at induction of labour, they saw that in the standard care group, 32.5% of women had an induction compared with 31% in the private group. And this resulted in an excess of 2,564 inductions in the standard care group. So 2,500 more inductions for public hospitals compared with private, and this was significant, which you can see by that confidence interval above 1. It looks like the 95% confidence interval is 1.1 to 1.1, but this is just because they've rounded up. It was, I think, 1.05 and 1.08. If we look at caesarean section, so any caesarean section, 31% had a Caesar in the standard public group compared with 47.9% in the private group. And this was a reduction of almost 30,000 caesarean sections for the public hospital compared with private, and a 50% reduction in the likelihood of a caesarean section. This was largely driven by planned caesarean sections, with, again, 31,000 less planned caesarean sections in the public group compared with the private group. There were also less unplanned caesarean sections in the standard maternity care group. I think there should be a negative here in the publication because there's 16% in the standard group and 19% in the private group. So, and the odds ratio below 1, suggesting that this was benefit towards the public system. However, there were more forceps birth for women in the public hospitals, but less vacuum births. So overall, it looks like in the standard maternity care group for mode of birth, they were more likely to have an induction, but less likely to have a caesarean section, more likely to have a forceps birth, and less likely for a vacuum birth. Next, they looked at gestational age at birth. And so they found that women in the public maternity care group were more likely to have a baby born less than 34 weeks. So there were 1,800 more babies born less than 34 weeks in that standard maternity care. But really important to note here that births are not typically planned less than 32, less than 34 weeks in the private sector. And so babies born, anticipated to be born less than 32 weeks will be transferred in labour or prior to this, if possible, so that these births would then actually be seen in the public arm. So this finding is probably not all that surprising. There were 2,000 less births between 34 to 37 weeks. So those late preterm births were less likely to happen in the public group. And similarly, 27,000 less early term births. So 37 to 39 weeks, they were less likely in the public system to have your baby early term. Conversely, when they looked at gestational age from 39 weeks, they were more likely to have their baby from 39 up to 41 and 6 was the cutoff for their population. So 27,000 more babies born after 39 weeks in this public care group compared with the private care group. And just important to keep these figures in mind when we look at the neonatal outcomes and thinking that we know that more babies were born less than 34 weeks and more babies born from 39 weeks. So now looking at those neonatal outcomes. So comparing standard versus private, they saw that for stillbirth and neonatal death, there were 778 more stillbirths and neonatal deaths, a twofold increase in the likelihood of stillbirth or neonatal death, with about 469 stillbirths and 309 neonatal deaths. But as I said, we need to really be considering transfers and referrals for early preterm births for those anticipated to be born less than 32 weeks, or if babies are going to be anticipated to need a NICU, they would also be transferred during pregnancy. So just keeping that in mind when we interpret this finding. They also saw more babies admitted to the neonatal intensive care unit in the public arm, so 2,300 more babies admitted to NICU with 3.5% versus 1.3%. But again, thinking about our referral pathways and when the high-risk patients getting transferred and those early preterm births getting transferred as well. There was more babies with a low APGAR, less than 7 and less than 4, so 2,747 babies with a low APGAR score of less than 7 and 368 less than 4. They were also more likely to have a birth weight less than the 5th centile and also more likely to have a birth weight between the 5th and the 10th centile. They were more likely in the public arm to have hypoxic ischemic encephalopathy with 54 more babies with HIE. But again, remembering there were more preterm babies in the public sector. So this needs to be considered when looking at this finding, and that the numbers are quite low. So 0.1% in the standard arm and 0 in the private arm, but I think that's just a rounding. It would be less than 0.1. There was more babies who experienced trauma with 94 babies and also more who had hypoxia. They also looked at maternal outcomes. So looking at those maternal outcomes, for perineal damage, there was more in the public care group again, so 3,273 women who experienced a 3rd or 4th degree tear, and this was largely 3rd degrees. But also you need to consider, again, there was more babies born after 39 weeks as well. It would be also interesting to see what LGA or large for gestational age babies look like between the two groups as well, but there isn't data for that. They did see more women experience maternal hemorrhage with 10,000 more cases in the public arm compared with private. There were more ruptured uteruses, with 34 more cases of uterine rupture in the public arm. Again, quite small numbers, so need to be a bit cautious when looking at that one. And interestingly, they found that they were more likely to have retained placenta in the public arm. So 1,500 more cases of retained placenta. They also looked at, outcomes by gestational age of birth. So importantly, they didn't adjust their analysis for gestational age, but they did stratify on it. So looking at stillbirth and neonatal death less than 28 weeks, this was increased in this arm. So a threefold increase in stillbirth or neonatal death for babies born less than 28 weeks. It is interesting that this is a finding. It would be good to see the absolute numbers for all of these complications, given that it's not routine that babies are born less than 28 weeks or planned to be born less than 28 weeks in the private setting. So they also saw an increase in NICU admission for less than 28 weeks. Again, this might indicate that referral. And then more likely to have low APGARs, but no difference in birth weight between the public and private group for babies born less than 28 weeks. When they looked at babies born between 29 and 32 weeks, there was no longer a significant difference in stillbirth or neonatal death. So we can see that those confidence intervals are crossing our null value of 1, suggesting no effect. But they did again see an increase in NICU admission, but no difference in APGARs or birth weight for these babies. Similarly, for babies born at 33 to 36 weeks, there was no significant difference in stillbirth or neonatal death, but still an increase in NICU, low APGARs and low birth weight. And then for babies born at term from 37 weeks, they saw again an increase in stillbirth or neonatal death, as well as NICU admission, APGAR and low birth weight. It would be interesting to see again what this looked like beyond term, so those after 40 weeks as well, because we know that they were more likely in the public sector to go beyond 39 weeks, but that data is not here. Importantly, they also did an intention to treat analysis. So all this meant was only for one state, because they didn't have the data for this for the other states. For one state, they had data on chosen model of care before 20 weeks. So if you were booked to have your baby in the private with a private obstetrician, but you were transferred over to a public hospital, your results still stayed in that private group. So this is just an intention to treat, again, one state, and for babies born after 28 weeks. And so for the main analysis, it was just wherever your final mode of birth was. And so the results were similar to the main analysis, but interestingly, there was an increase in stillbirth and neonatal death, so a 4.5-fold increase in the likelihood of stillbirth or neonatal death for public compared with private in this analysis. And the numbers must have been quite low because they weren't able to report, or low in one arm, stillbirth or neonatal death for individually. These findings are interesting. I would have assumed that it would have been somewhat attenuated because those babies who had been transferred over to the public system in their main analysis now stayed in the private group, but this wasn't the case. And so, again, there was an increase in stillbirth, neonatal death, NICU, low APGARs, low birth weight. The numbers might have been too small for HIE, but an increase in trauma, hypoxia, and perineal damage as well in this analysis. Importantly, they also did a cost analysis to try and see, okay, what if the clinical outcomes look like this, what does it actually cost? So this was based on one state, so not the three, a bit of a smaller cohort, and it was birthed from 2016 to July 2018, and the cohort's a bit smaller because it's just one state, and they did again that matched analysis. And this was 33,857 women in the standard care group versus 33,857 in the private group, and looked at total cost and then who was really fitting the bill for those costs. So in total, for one birth in the standard maternity care group, they found that on average this cost $28,645. Whereas in the private obstetric-led care, it cost $22,757, so a mean difference of about $6,000, with the public hospital being cheaper compared to private. More expensive. And so looking at who really took this cost, so the public hospital funders costs $26,499 on average, but for the private system, the public hospital funder was $1,700. Looking at private health insurance, this was about $100 for women in the public arm versus about $13,000 for the private obstetric care arm. And also looking at Medicare, this was $1,500 for the public hospital arm and about $3,800 for the private arm. And then our pharmaceutical benefit scheme. So this is just a government subsidised medication. So the government subsidised some medications, and so this is the cost for those that were utilised between each groups. And that was $99 for the public arm on average and $135 for the private. But the main difference here is that patient out-of-pocket cost. So $472 in the public arm, and this may have been attributed to things like scans not done in the hospital or genetic testing. But not entirely clear, it's not reported. And then for the private obstetric care, this was on average an out-of-pocket cost of $4,285. But again, not entirely clear whether this was just the out-of-pocket fee for the obstetrician or whether it covered all those additional costs that patients do have to cover in the private hospital sector as well. Okay, so some important things to note. I think, again, this is a big study and they were able to get large numbers from 3 states, which is really impressive, and undertaking a matched analysis to try and balance out those differences, which attenuates some of that confounding, is a good approach. But they also, some of the results may have some potential for referral bias, remembering that private patients are referred to tertiary centres. That's how the system's set up to work, that they work hand in hand to really care for patients as they become more complicated. That's both for mum and baby. So there is that potential for referral bias. Again, we saw that there were more early preterm births in the standard care group and more births after 39 weeks, and that the neonatal outcomes were not adjusted for gestational age at birth. So we need to consider that when we're looking at their findings. Although they've done a great job in using a matched analysis and did achieve balance for most of those variables, it is really difficult to control for all potential confounders. You can only control for what you have in your data set. So that's not on the team. It's just based on what the data that they have. BMI was not balanced, as we saw. It was, I think, 30 and 26, so a significant difference there. And there was missing matching variables for some of the states. They also had over 20 outcomes. We do need to be also mindful of the potential for type 1 error. So that just means that some of those outcomes, not all, may have been due to chance. It's also unclear what out-of-pocket costs were included. I couldn't see it in the manuscript. And we need to consider whether it includes the many fees that patients do have to pay for in the private setting. So thinking about those initial consult fees, the pregnancy management fee to the obstetrician, gaps for other specialists. So if you're in the private system and you see the anaesthetist, there may be an additional gap. Same for the paediatrician, if there's surgical assistants, if you see a physio in hospital, those additional costs. As well as the routine ultrasounds are not covered at all in the private system. Patients would be paying for those out of pocket. And also, of course, genetic testing, which would be the same for the public group as well. I think, again, just really important to note that all of these models of care aim to work together to provide safe delivery of care for mums and babies. And now we're going to head over to our expert panel. And thank you.
I'll ask the panel to all come on with their videos. Oh, my video was already on. Okay, well, thank you very much, Roxanne. She'll join us very shortly, and that was just a really excellent summary. So I thought what we would do is perhaps to just go around the panel for any thoughts and reflections, and if someone preceding you has covered most of your comments, you can pass or whatever, but it's up to you. So I'll just choose random. Perhaps we might just start with Aris. Feel free to just keep it.
Thank you. Thank you very much. I mean, a beautiful presentation, Roxanne. I was thinking about what is the bottom line, and I think to me the bottom line is this is a well constructed. It's a very large matched cohort study. Using that linked administrative data. And it shows consistently worse outcomes, understand the public care versus private care. But there are two big things that a study like this cannot overcome. The first is what you mentioned, which is residual confounding. And, for those people who are not into cohort studies, residual confounding essentially means there are lots of things that women's characteristics that you have not been able to measure. So, for example, individual level socioeconomic status of each individual woman, the education, the health literacy of a woman, perinatal mental health issues. So those are individual patient factors. Then there are facility level factors, like, facility level facilities and protocols. So that these are the sorts of things that you can't control for. And then the other big thing for me is that the paper kind of conflates the model of care with the hospital sector. So private obstetric-led care happens in different places than standard care. So how much of it is the care and how much of it is differences in infrastructure and staffing and transfer policies, etc. But what's striking to me is actually the consistency of the endpoints. And I go back to, I think this is I think overall this is a well done study, despite those limitations, which the authors acknowledge. And I think, one of the important things for me is that the outcomes, which are all pre-specified and, they're well coded, they're really consistent. So the direction of the effect is always the same. These are not sort of random little bits of information. And that to me is important. So, within any paper, there are strengths and limitations. And I think certainly this paper does have its limitations, but it does also suggest that there is something important there that we need to take into account. And, we all work on trying to improve maternal and perinatal health outcomes. And, this is just showing that, some of these outcomes seem to be better in that sector. What would be helpful maybe for our international audience, Stephen, is to maybe very briefly outline how the system works in Australia, because private care and standard public care, health care is maybe a little bit different in different settings. And I don't know if it's possible to really just briefly explain how that looks like in Australia. Thank you.
Okay, I'll give that go in a nutshell. I think Rox had given it a go. I recall in the paper about 75% do the public care model, where essentially care is close to free, and that's probably the default setting of everyone. Or you can wish to go to the private care model, which is 25%. If you go on the private model, it's ideal that you have pre-existing private health care. Otherwise, it's really very unduly expensive. Most of the private care model is in its own shadow infrastructure system, just as Iris had mentioned. They're private maternity centres, all with their own setup, etc. Some people do seek private care embedded at public hospitals or bigger public units, but that's only a minority care. So most it's pretty much a shadow. So you do book in to see your private obstetrician, and there are costs involved, and they charge a management fee, and you deliver it in that private hospital. Now, the public system, I'm just trying to keep it as an overview, is a bit of a potpourri of different care, and I think one of the letter's editors had just made that point. It really is a potpourri. It may involve continuity of midwifery care model, which has been shown in previous studies to be an excellent model. It also, in that pot will be high-risk obstetrics, where maternal fetal medicine specialists are usually offer their care under the public system. So that's a lot of the most highest risk, and they're often referred in early pregnancy. I'll see whether Sue thinks otherwise. I might defer to her next to catch any errors that I'd mentioned or anything else in the model that I'm missing. But I suppose that's the other thing. If they're pretty high risk at the start, often they will default to maternal subspecialty care. But the majority of public care is this mixed model, where you'll see a mix of obstetricians, trainees, or midwives in clinic. you'll often turn up to birth suite and it will be the team on the day that delivers you. So that's what the authors called fragmented care. You could go on, but I think that's some sort of overview. I might defer to Sue for her thoughts on the paper and anything else about the models which I'm missing, which may be useful for the international audience.
Yeah, thanks, Stephen. Yeah, I think it's impossible to describe every model of care that's available, but I think you've summarised the major differences well. I mean, there have been a couple of comments in the chat. Natasha's outlined that not all public care is equal, given the complexity burden that tends to find itself in the public sector. But Gino has also made the point that, there are health services in Australia where you can continue to have your private care right through to level 6 NICU care, which really goes to Iris's point, I suppose, about just conflating institution with model of care. But I think it's fair to say that the majority, and I think Graham's put something in the chat about that, certainly in Victoria, almost all level 6 is in public or public-private care. I mean, my thoughts about the paper, I agree with Iris. I think that we should be holding outcomes up to scrutiny and seeing, are there measurable differences that we can then try and provide care that provides better outcomes more equitably. I think matching, of course, is not the same as randomisation, and it's not feasible or ethical to do so. And I think there are probably unmeasured confounding in this paper, some of which have been alluded to, as you've said, in the discussion by the authors. But I think particularly the social determinants of health, there are many of those that we just can't quite capture given the limitations of the data set, but maybe also some of the health seeking and risk minimising behaviour that you might expect to find a little bit more both in the private sector and that is captured well in a relationship between a private practitioner and their patient. I mean, I think my second concern is perhaps just that reduction in mortality and some of the language around that, the excess deaths that occur in public. I think we just have to be aware of the gestational age where that is occurring, and that much of that is driven by the excess of preterm births that are occurring in the public sector. Jeremy's made a very good point, and I'll be interested in Gordon's and other comments. Is not some of this increase in stillbirth rate partly due to the reduction in early term and late preterm birth in the public sector? And perhaps something else that's helpful for an international audience to know is about the Preterm Birth Alliance Prevention Program, which is really trying to prioritise all non-medically indicated births being after 39 weeks. Whereas if I'm correct in this paper, I think nearly 50% of births in the private sector were before or up to 39 weeks. Rox, correct me if I'm wrong about that. But I think Jeremy's point about how that might be impacting on stillbirth rates is important because, of course, if you're no longer pregnant, you can't have a stillbirth. But I think, there are very important elements of, private care which have been well brought out in the paper. It confers some benefit, that it provides patient choice. There's a shared relationship, values and alignment in terms of what are women's birth preferences. And I think the challenge that is posed to us is how can we create systems that provide all women with sufficient information that they can have agency over pregnancy and birthing. How do we create those safe and trusted environments where these sorts of outcomes can be replicated across those groups who are most vulnerable and most likely to be in public care that have been outlined in the paper. So I guess they were some of my preliminary thoughts and response to public versus private.
No, thank you so much, Sue. I might just remind the audience that we can't address hands up. So please just put your notes on the chat. We can't address raised hands, so sorry. So perhaps I'll just bounce between countries and I might maybe go next to Gordon, then Christine. Sorry, Chris. I'm just getting geographically a bit challenged here. I'll go to Gordon, Christine, and then Jenny. So Gordon next.
Yeah, thanks. So just to, I won't labour the residual confounding issue, but I think when you consider the possibility of residual confounding, you look at the data, so the demographic differences between the two groups, were of a scale that I don't think I've actually ever seen in an analysis before. So the rate of teenage pregnancy in the public group was between 35 and 40 times higher, not 35 to 40% higher, but 35 to 40-fold. Obesity was 60% higher. Aboriginal and Torres Strait Islander was greater than 10 times higher, and smoking was 20 times higher. I can't think of a paper where I've seen those sorts of differences. And that's the sort of thing that makes you think there's a danger that this thing that you have measured is more of an indicator of the characteristics of that person than everything else you've measured to try and account for the confounding. I mean, I think that absolutely the thing you're thinking here is residual confounding. One of the things that helps you identify residual confounding is if you compare the unadjusted and the adjusted association. So if you see an unadjusted odds ratio of 2 and an adjusted odds ratio of 1.95, you think, well, having adjusted for the confounders we can measure, there was virtually no effect. It's less likely there's residual confounding. But nowhere in the paper do you see the unadjusted odds ratios. I suspect they would be through the roof, if you just compared the two groups. But that lack of a univariate analysis means that you don't have the capacity to understand to what extent did the matching process attenuate the unadjusted associations. So I think the residual confounding here thing is just unrecoverable. The two groups are so different. I don't think it's possible to do an analysis that takes the confounding into account. The thing that maybe hasn't been touched on is the actual economic analysis itself. So I just don't know how. I didn't have time to go. I mean, I went to the paper that was cited, and the paper that was cited was a study protocol. That study protocol was itself cited by another paper published in 2021, which looked at the cost of maternity care and the first 1,000 days of life for the neonate and said the costs were higher in the private system, and it was the same first author. So actually, when you took into account the neonatal care, the costs appear to be higher. And I can post the PubMed. I'll post the PubMed link into the chat for that. But the other thing is, to what extent does the economic analysis capture the difference between the two systems? I mean, if you're in a top-tier system and you have to have an intensive care unit, a coronary care unit, a neurocritical care unit, a level 3 NICU, are we absolutely sure that there's an enormous saving by not having to have these services that you, particularly like the specialist medical units, you'd only ever have to use very, very occasionally. But that's the public sector has to offer that at the highest tier, 24 hours a day, 7 days a week, 52 weeks a year. There's no option. And there's an enormous saving in costs. And I would want to be confident that the economic analysis definitely captured all of those costs. And then, just to say, there's no analysis of the neonatal care costs. That's another part of this that's missing. And the previous publication from the same author actually said once you take into account the neonatal costs, the private sector was more expensive. So I think this is an impossible analysis to do. Actually, I think it would be. It's a level of confounding that I think it'd be extremely difficult to make a valid comparison of the two groups. I think it'd be good to know a little bit more about how the economic analysis was done. Does it really take into account completely the fact that the public sector is offering services that the private sector, extremely expensive services that might only be used very occasionally, that the private sector just doesn't have to provide at all? So
can I just follow up, Gordon? So you think that the study question itself, if you had access to the administrative data and things that are typically put in, you would just say, no, that question is not answerable, or would you have done the analysis in a different way?
I'd say it's just not answerable. You're comparing two populations that are just too on a link. And what I would like to have seen is the unadjusted analysis, to see what was the effect of the adjustment that they managed to make. That's something that was within their power to report. I suspect if they do that, you'd have seen much stronger associations univariate, and then these would be massively attenuated by matching, and then that would have raised the concern that the remaining associations caused by the things that you couldn't match for.
Right. So your concern is that even with the matching, or if you did inverse probability weighting, there's just a suspicion of...
Just no way you can get around it. Yeah.
All right.
That would be my assessment. I wouldn't have embarked on it.
Okay. Right. So Christine,
Thanks, Stephen. And as we mentioned at the beginning, I'm a midwife and I'm representing my own opinions here. I can't claim to represent the opinions of all midwives. So I think this is a stellar group of authors. They have done an amazing job of this. And the first author, as has been alluded to, ran the economic analysis to show that continuity of midwifery care was very cost effective and it could be scaled up at a much greater scale to benefit women and provide choice to them as well. And another study has also done a three-way comparison in the past between midwifery continuity of care models in the public system and the private system and came out with favourable for midwifery continuity of care. And I wonder within the data set if they were able to break down this very non-homogenous group of hospital care. Because there's hospital care and there's hospital care. We have multiple models in every hospital I've ever worked at. We have women wanting to be able to make a choice. And so in our hospitals, it's almost ballot, but not quite. The midwifery models of care, continuity of care, which is around 10-11% throughout Australia, and that's mentioned in the paper. More women than wanting that are able to access that. What about the really complex care, that sort of thing? So how do we offer women choice when they look at the results of this paper? If they have a complex pregnancy, do they go to the public system because the costs are going to be much better for them? Or if they want continuity of obstetric care, they go privately? And I think to their credit, this is one of the few papers that can show that continuity of care can make a difference. And in this case, it's obstetric care. And there will be other factors in there as well as the continuity of care there. Continuity of midwifery care, why can't this have been done breaking these down? I don't know if the data sets allow for that, but I think it makes it very difficult for women to then make an informed choice as to where to go for their pregnancy and their birth if they're then scared by a paper such as this that says they'll do worse if they go public. But if they go private, nearly 50% chance of a Caesar. So
Thanks.
not sure where to go with that. I've looked at these matching and I went, wow, that's amazing. I've looked at the economic thing that's out of my league and I go, that's amazing. But it's not giving me the answers that make sense to me. And as Greg has said here just now and also in a previous comment, the obstetrician care can provide everything all at once. So if they need a vacuum forceps Caesar, the obstetricians can do that. Women in a midwifery-led model or in a collaborative model that's working within the hospital system will then work with the doctors to then have other options other than a normal vaginal birth. So there's care. Yes, a known care provider is hugely, hugely important. What kind of choices do women have? And particularly when they're faced with such horrendous out-of-pocket costs, acknowledging that the private insurers who are paying this, that money has come from pregnant women over a long period of time. Some of those who are accessing the system at that time and some who have previously accessed it. So lots of comments in there. Not sure if they help, but it would be really good if there could be a further breakdown to be comparing apples with apples, because it's very clear that we're not something else is going on despite the beautiful matching.
Yep. Maybe Graham on the line or Roxanne might be able to know that, but I just don't think that we've got it's unlikely that the administrative data has granular data that we can be confident that we can look at the different models of care within the public sector. But it's a good comment. Okay, I might just now go to Professor Jenny Myers in Manchester for her comments.
Yeah, thank you all. And I kind of echo a lot of the comments about this being, a large and well-conducted analysis with the data that was available. But we've talked about the very big differences between the populations, which, as Gordon says, there is just no way to get round. And as Sue highlighted, the health-seeking behaviours of people who have invested in their own healthcare and have made choices and prioritised their own healthcare or are able to do that, will always identify a different group of women. And I don't think any amount of matching we'll be able to get rid of that residual confounding. I mean, the scale of the matching itself is quite incredible. There are 122,880 strata from those different matching groups, which I think puts into perspective the numbers of people that will have been in each of those strata. So I think just the way that comparison works is really very complicated and doesn't get rid of that residual confounding. But some of the thoughts that maybe we've not dwelled on so much as well is some of I would have really liked to have seen some, and perhaps this might come in secondary analysis, but some investigation of modifiable stillbirth, because what's really important here is what are the things that we could change about care in different models that would actually be associated with better outcomes, particularly stillbirths. We've talked a lot about the effects of gestation, and that we really need to see some kind of analysis, that there are numbers available, I think, in this analysis to look at the later stillbirths, to look at whether they were intrapartum, whether they were antenatal, were they in the small babies, where were the excess stillbirths, which groups were they in women with medical disease. So I think there's an opportunity there to kind of interrogate some of those outcomes in terms of implementing findings here and thinking about what are the bits that we should be targeting within our different models of care that might actually make a difference. So I think that would be really interesting. What do we know about access to screening, access to disease-modifying drugs? Very simply, things like aspirin use, those kind of things. Are they equitable between the different models of care? Are there opportunities to target different behaviours there? The other thing that really struck me was the direction of causality of some of the observations. So in the very last bit of the analysis, there's some adjusted odds ratios around the risks of stillbirth using the model of care. There aren't any interaction terms in that analysis, so it's a straight adjusted analysis. And there are some slightly surprising observations there in terms of, for example, preeclampsia is not associated with increase in stillbirth, which you perhaps would have expected. And also the caesarean section, once you've had a stillbirth, you're not going to be offered a caesarean section. And so that analysis needs to be done in a slightly different way, because you'll be induced if you've had a stillbirth most of the time, if it's an antepartum stillbirth, and you won't be offered a caesarean section. So I think some of those bits could be perhaps explored in a bit more depth to just really think about what does that direction mean. And as Rox pointed out, the intention to treat analysis seems to take the effect in an unsurprising direction, and I think that needs some more exploration. And perhaps, if I may, Stephen, my final point is really already been highlighted, is about the responsibility we have of us all to ensure that we're not alarming and being sensationalist about these kind of publications. And I think that's really important, because it's not an option for many women to choose private care. And what we don't want is women running for the hills and not accessing the very high quality public care which is available to them. So I think we have got to be careful and measured about some of the headlines, which I'm sure this paper has generated.
Okay, can I be provocative to the whole panel then? So we probably lean towards the side of a few criticisms voiced. So if I was a private obstetrician watching this, I think that I'm giving better care. Do you just think that maybe we all work in the public system and therefore we might have had a biased lens in looking at the data? Gordon will probably say no, but do you think that we've just been a little bit heavy on the paper with our own pre-existing biases, or we're pretty sure that that's not the case? Jenny?
I think that there are inherent biases in it just because of the data available and the populations that we've studied. So I think that you can't get around that, and people who are able to choose a different model of care with different levels of health literacy will be having will have better outcomes. I think we also do need to highlight, though, that there was a lot more intervention in that group and a lot more late preterm births. So it's not all better in that group. Obviously the catastrophic outcomes of deaths were lower, but a very significant increase in late preterm births is not insignificant. So we've always got to balance intervention with benefit.
Okay, this is my last attempt. So if you just turn the whole panel back by a few decades and you're pregnant, boy or girl, and you're a good you have the same epidemiological knowledge that you have, but you're personally invested. You look at this data. Would it have moved your dial even a little bit if you're trying to decide which models of care?
I guess question, Stephen, sometimes is to root or your experience. I do know private obstetrics, and I know that none of the panel do here today. But the authors are careful, I think, not to ascribe too much in terms of causality. They're saying this is what happens in this setting and this is what happens in the other setting. There is some discussion around what could be modifying some of that, but they're not saying these women are having better outcomes because they're in private care. They're saying these are the outcomes that are associated with private care and public care. And there are lots of confounders, as we've talked about. There are also important mediators, as Jenny says. So in the private care, more women had cesarean section. A higher proportion of women were born at 37 to 39 weeks. And, if you're born at 37 weeks, you can't have a stillbirth at 39 weeks. You can have a perinatal death. But by definition, if you're no longer in utero. So those things influence intrapartum stillbirth and neonatal outcomes as well. So I guess one of the questions I have is, when I look at these data, how do they chime with real world, right? Now, I'm not saying for a second that the women are the same at all. I'm saying in the real world, what do I see? I live in London. There's plenty of private obstetrics happening here. And I very, very rarely see very, maternal perinatal deaths in the private sector. And I'm not saying that's because it's the sector. I'm saying that's a multitude of reasons. Women are healthier to start with. There is almost certainly an issue of continuity of care. It's been picked up by a number of commentators. Very important, and has been shown to be important. There's a workload, the caseload. A private obstetrician, a busy private obstetrician might do 100 births in a year. How many births does a private midwife, a public health midwife or medical doctor do? So, all of those things do play into it. And I think the cost effectiveness ultimately is going to be some of the driver of that quality of care. And then finally, in the private sector, there's a massive reputational element. The private obstetricians on the webinar will know this. A private obstetrician is absolutely terrified about the potential for a stillbirth or an adverse outcome because it has the potential to impact their personal reputation massively. And maybe the same is not true for public care. I'm not saying that it doesn't have an effect personally deeply for people who are involved in adverse outcomes, but maybe it's a little bit different. So listen, as I said at the start, there isn't a paper that hasn't got, benefits and disadvantages, and this certainly has both too. But, I do think there are some data there, and as I think Jenny says, maybe our job is to try and figure out what it is that, is associated with those better outcomes. And if that is that women have better healthcare seeking behaviors in the private care, well, that's important. How can we instill that more generally? If it's that people care more about their personal health, that's important. If it's more about continuity, that's important. If it's around gestation age at birth, those are all important factors. Because what's clear is that if you could replicate some of these outcomes, you'd certainly save a lot of perinatal deaths, confounding or not.
Thank you very much, Iris. Does the panel have any final comments before I might just see whether Sue can draw in a discussion from the chat? Does anyone else have any comments? Okay. Sue, have you picked anything of note in the chat?
No, I mean, I just wanted to, really echo some of what Iris said. Sort of personally, the medico-legal and the reputational risk does make a bit of a difference in the way that private care is delivered. And as many have said in the chat, it does provide a genuine continuity of care from whatever happens from the very beginning to the very end of pregnancy. There's a relationship that is there in the private patient with their clinician, that if we're honest, many of us either would or have chosen that. There is an opportunity for birthing and pregnancy preferences to be really well aligned. And as I say, Chris Griffin has pulled that out by talking about a patient-clinician alliance that you can develop in private that you can't do in public in the same way. And I think it's also important for us to note that it is our private clinicians, many of them who also work in the public sector, who sometimes do very much of the heavy lifting of our training of future specialists, our teaching of medical students, and also, providing public care as well. So there are opportunities to do more there. In terms of the questions, Kate Walker's joined us. Lovely to have you with us again, Kate. The time horizon of the study she has alluded to. So we've talked about what might be the baby consequences of increased early term and late preterm birth in the private sector, but she's also talked about the 47% caesarean section rate and how that might have important maternal safety implications. And Rock, sorry to put you on the spot, but she's just asked you, can you comment on the methodology of stratifying by gestational age but not adjusted for gestational age, if that's not too hard for our tired heads to comprehend at this hour?
Yeah, I think it is important that that wasn't adjusted for, but I think it's because they wanted to look at timing of birth as an outcome. So it's difficult to adjust for something that is also an outcome. And that would be why they've done it. It would be really interesting to see what the results do look like if you do adjust for those very preterm babies, those less than 28 weekers, and then the post-term births as well, just to see if there is change after considering adjustment there. And when they did stratify, it was only term, so from 37, it would be nice to see what would look after 40, but they might have that data and it might come later.
Yeah, thanks, Rox. And another question that's just sort of followed that question was just what the panel thinks about this creation of a new data collection model when there's already a WHO recognised data model in the Robson 10. Rox, you'd probably be able to give us some idea in terms of, are there limitations with the perinatal data collection in terms of being able to align it to Robson 10?
I don't know the Robson 10 variables off the top of my head, Sue. Sorry.
Yeah.
Can't answer that one, but it would be good if we could be more universal, or just have a bit more access to perinatal data here in Australia in general.
Yeah. Okay, great. There are a couple of really important points. Sarah, really picking up what Jenny was saying as well, that the media reporting on this study was problematic and that in particular midwives felt the brunt of that a little bit. And that I think this panel has been a very important place for us to try and re-centre that commentary. I think some of the language in the paper, but certainly in the media surrounding it, has been perhaps a little bit unhelpful in terms of being able to focus on, as you say, Australia being one of the safest places to birth or to be born, and that most of that is indeed done in the public sector. So I agree with you, Sarah. I think we did have a bit of a problem with how this was messaged. I know over here in the UK, they're talking about, a maternity crisis. I think that does nothing to help actually in terms of identifying what are the messages from this paper that we might be able to take into public sector to improve maternity care for all, which actually is already at a very high standard. So that's an important thing.
Sue, I would also just add, we do have both sides, and a bit of the chat, I will completely acknowledge that a lot of people who do private obstetrics were not saying that private obstetrics is there's a comment here that private obstetrics is therefore worse or equal. It may be better, but we're just sticking with the methodology. So I'm sorry if aspects of the criticism of the paper has bothered you, but just be aware we're not making any commentary that your private obstetrics is equal, better, or worse in this particular instance. Before I throw to Jenny, I think Gordon just wanted to make a comment about the gestational age correction point.
Yeah, I mean, I think there was a query about whether the earlier gestation age of delivery might be one of the sort of factors which determined the different rates of stillbirth. So, I mean, overall, about 1/3 of stillbirths tend to occur at term. That's certainly in the UK. I think it'll probably be pretty similar in Australia as well. So if you just delivered everybody at the start of the 37th week, you would reduce stillbirth by 1/3, but then you'd have a lot of attendant short and long-term morbidity for the baby consequent on that. So the maximum reduction you would get is you just delivered everybody at the start of term would be about 30%. So and obviously the distribution of gestation age in the private group was much more even. There was a lot of births at 39 weeks and beyond. So I would have thought that sort of earlier intervention it certainly couldn't result in a doubling of or halving in the rate to lead to an odds ratio of 2. So I think again it's most likely that the variation in stillbirth is due to the unmeasured confounders. And I guess that's one of the other things about it. When you see every association differing between two groups, that's not reassuring that you're measuring something real. That's maybe sort of concerning that you're measuring something else, because there's not many sort of interventions that prevent absolutely everything. That's the very sort of pleiotropic effects of this, apparent associations of this, are one of the things that makes you feel it can't all be explained by the pattern of care.
Thank you, Gordon. Jenny.
Sorry, getting off mute. Yeah, I mean, I've been asking myself this question a lot the last 24 hours. Like, if you were, and clearly it would be absolutely impossible for lots of reasons, but if you were to do a randomized control trial that allocated everybody to these two different models of care, who genuinely thinks we would come out with the same findings, if that's possible? And I think that's one of the ways of just spinning the question on its head a little bit as to the unmeasured confounding. I think when you think about the complexity about randomizing people to different models of care, it starts to reveal immediately what the very significant differences are between groups of people in these different models of care. So I think that's just worth mulling over in terms of how we interpret the findings. If we consider an RCT to be the gold standard, which it isn't always, but if we were to consider that as the gold standard for determining outcomes in terms of causal effects, I think it's worth mulling over whether any of us genuinely think the outcomes would have been the same if it were possible to do an RCT.
Okay. So are there any big thoughts that we haven't really covered before, because we probably start thinking of wrapping it up without rushing any valuable comments from the audience?
Look, there are really valuable comments about things like birth trauma and so forth, which we're not really able to address and answer, but we all acknowledge the benefits of continuity of care, and that some of that is going to be unmeasured because it's going to be in the postnatal sector. I think probably those are the main additional things, the increase in intervention, the increase in late preterm birth, but that being, offset against, obviously some of the improved outcomes. I think other things about the unmeasured confounding are probably the major things, that it's just making it very difficult to compare the groups. I'm sorry if I'm misrepresenting anybody's major point. If you've got a major thing that you want to pop in the chat, please do. I appreciate it. It's a complex discussion to get balanced and right.
Great. Well, I might just start wrapping up. I might just say quickly to the panelists, Bella sent just a quick housekeeping, a web link address. If you just don't mind just jumping straight on, if you just got a bit of time after this, because we can't stay on here. Okay, well, we've covered this paper and we've dissected it quite a bit. What I'm hearing, and just correct me if I'm just misrepresenting, it was just really well done across 3 states and a really good attempt with matching to address a question which clearly has a lot of interest all over Australia. Perhaps some things is the residual confounding, which Gordon's particularly concerned about, the unmeasured differences between the populations accounting for the findings that we see. There may be an issue of referral bias that if you are preterm and there is a concern, you might be sent to the public system, although the intention to treat analysis might just go some way to alleviating that. But our other point is that we have the data and we see differences, and I think a few of us have just said maybe really what we should apply the lens to this valuable paper is to maybe start looking at, we've seen the differences and maybe just starting to know that they're there, and it may be valuable to now put a little bit of a focus on trying to understand the differences to see whether there's things that we can do to make maternity care better, either in the public or private system, perhaps. I am going to end that I have had contact from a lot of colleagues and friends beforehand. I think where we've landed as a panel, some people who practice privately might not agree with, and that's absolutely fine. And if they don't agree with how we've academically digested the paper, that's absolutely fine. What I want to just say to my private colleagues, and I've done a bit of private practice for 10 years, and I've really loved doing that and look after my patients well, I hope, that this is not a criticism, it's not even a comment that the practice of private leads to equal outcomes, and this paper doesn't have anything in it. It's just some limitations to consider in the paper, and it's definitely not a criticism of private care at all, nor is it a criticism of public, and I don't think we would have won everyone over that, but I attempt there with a final editorial. But I do thank the panel for joining us. I thank the audience so much for joining us as we chatted over this important paper. I thank Iris, Gordon, Christine to represent the midwifery group, Jenny Myers over in Manchester. Thank you so much to the team, importantly Roxanne, Bella, Preston for providing a lot of the tech support. And thank you so much for the audience for joining and supporting us. And we'll catch you at the next Mercy Perinatal or Scan Academy event. Thank you very much.